Okay, so we're going to move on to diseases that affect thyroid function. And the first condition we're going to talk about is what we call non-toxic goiter. Now, with non-toxic goiter, we have an enlargement of the thyroid gland. Any kind of enlargement of the thyroid gland is described as a goiter. And the goiter that we have in this image here is obviously extreme, right? So this woman's goiter is much, much larger than you would normally see a goiter getting. So this is likely a woman who does not have really good access to medical care, and so her goiter became so extreme before she finally really had to go to probably extreme lengths to get it taken care of or even seen. But a goiter can actually be difficult to see. Sometimes you won't be able to see it at all. Sometimes it's just something that a clinician can palpate, and they can feel that the thyroid gland is enlarged. But with a non-toxic goiter, the reason why we call it non-toxic is because even though there is a goiter, the thyroid hormone level is normal. So when we look at somebody, do an assessment of their hormone levels, someone with a goiter like this, what we will find is there will be changes in their hormone level, but not in their thyroid hormone. So we know that TRH from the hypothalamus, right, is acting on the anterior pituitary to stimulate the production of TSH. Okay, so the anterior pituitary releases TSH. And then TSH acts on the thyroid gland to stimulate the production of thyroid hormone. All right. And then we also know that thyroid hormone provides negative feedback regulation at the level of the hypothalamus, right, and at the level of the anterior pituitary. So what we see with a non-toxic goiter is we see elevated TRH, we see elevated TSH, but normal thyroid hormone. Okay? So normal thyroid hormone, but elevated TRH and elevated TSH. So what's going on here? So in a non-toxic goiter, and then by the way, the fact that TSH is elevated is the reason for the goiter. Okay? TSH, thyroid stimulating hormone, not only stimulates thyroid cells to produce thyroid hormone, but it also stimulates thyroid gland cells to proliferate, right, to get bigger and to increase in number. So hypertrophy, hyperplasia of the thyroid gland is stimulated when TSH is elevated. And so that elevated TSH is the reason why we see goiter. Now, what started this whole problem? With a non-toxic goiter, there is some change in thyroid function. The gland itself becomes less capable of producing thyroid hormone. So you might have in the development of a non-toxic goiter, you might have a brief period of time where thyroid hormone levels are actually reduced. But that reduction in thyroid hormone level, that temporary reduction, causes a reduction in the negative feedback, which elevates TRH and elevates TSH. And so now, with that elevated TSH, the thyroid gland can get bigger and can now manage to produce a normal amount of thyroid hormone. Okay. And so the result is an enlarged thyroid gland because of elevated TSH, but it's an impaired gland. So it's an enlarged gland that now can function as normal because it's getting sort of like extra stimulation from the TSH. Okay. So goiter is an interesting sign, right? A goiter is an interesting sign. A goiter is absolutely a sign of some kind of thyroid condition, but we can see goiter in with normal thyroid levels, like a non-toxic goiter. We can see goiter in hypothyroidism, where thyroid hormone levels are low. And there's even one kind of hyperthyroid condition where we see a goiter. So seeing a goiter is not a given for whether this is a hyperthyroid condition or a hypothyroid condition, or even that thyroid hormone levels are going to be abnormal at all. They could be normal. This could be non-toxic goiter. Okay. But what we do know when we see goiter, one thing we do know when we see goiter is there's either an elevation of TSH that's enlarging the gland, or there's an elevation of some hormone or some mediator that is enlarging the gland. Okay, so just a reminder again of the axis that we're talking about here. We're talking about these hypothalamic cells releasing TRH, acting on the anterior pituitary, on those thyrotrope cells, stimulating them to release TSH, and then TSH getting into the bloodstream, acting on the thyroid gland, which is right there in the neck. It's a size, it's a shape of a bow tie. It's sort of exactly where a bow tie would be. Thyroid gland, TSH stimulates it to release thyroid hormone. And then thyroid hormone provides negative feedback onto the hypothalamus and the thyroid gland. So first let's talk about hypothyroidism. So we talked about one condition where there's clearly something wrong, evidenced by this goiter, but thyroid hormone levels were normal. But we also have conditions where thyroid hormone levels are deficient, they're low. Causes of thyroid hormone deficiency can either be primary hyperthyroidism, right, where the primary problem is some condition originating with the thyroid gland, or it can involve other causes. So primary hypothyroidism, the most common cause, is an autoimmune disorder called Hashimoto's thyroiditis. That's the most common cause of primary hyperthyroidism. But we also see sometimes congenital disorders that affect thyroid hormone synthesis. So genetic abnormalities, genetic mutations in the genes that code for thyroid hormone, that can produce hypothyroidism. Another extremely common cause of hypothyroidism is iodine deficiency. Iodine is a component of thyroid hormone, and it is the only component of thyroid hormone that we cannot synthesize. Iodine is a dietary mineral. We must consume it through our diet. And iodine's not all that easy to come by. Iodine is found in plant material that grows in the oceans. And so if you happen to live somewhere where you are living by an ocean, you're probably eating enough seafood and you're probably getting plenty of iodine. If you don't live by an ocean, but you do manage to eat a reasonable amount of seafood, you're probably getting enough iodine. If you don't live by an ocean, you might be getting iodine from the soil. So there's still iodine in the soil wherever there was a salt water bed that's now no longer there. The salt water got into the soil and gets into, or the iodine from that salt water got into the soil and gets into the plants that are grown. But most people actually get iodine from their salt. Many years ago, the United States and many other countries started adding iodine to their table salt in order to make sure that everybody got enough iodine. So today you can go to the store and you can get iodized salt and you can get non-iodized salt. And just so you know, if you happen to be a fan of gourmet salts like sea salt or Himalayan pink salt, right? Many of those products are not iodized. So if you are solely consuming sea salt, coarse sea salt or gourmet salt or Himalayan pink salt, just be careful that you it could be iodized. There are versions of it that they've added iodine to it. But if it's not iodized, then make sure that you're getting some other source of iodine. Primary hypothyroidism can also be complications of medical treatment. So post-radioactive iodine treatment for hyperthyroidism. So if you happen to have hyperthyroidism, one way of treating hyperthyroidism is to actually give you radioactive iodine, a very carefully dosed radioactive iodine, and that destroys the excess thyroid gland and should bring you back down to sort of normal thyroid hormone levels. But if you are overdosed, if you take too much of the post-radioactive iodine or radioactive iodine, if you're given a little bit too much, then you could end up becoming hypothyroidism. So it's a complication of that procedure. It's pretty rare. The dosing of the radioactive iodine is actually quite precise. There are people who have radiation therapy for head and neck cancers or lymphoma that can destroy the thyroid gland and lead to hypothyroidism. And then obviously getting a total or subtotal thyroidectomy, having your thyroid gland removed, obviously will leave you without enough tissue to produce a thyroid hormone. Thyroidectomy is usually the treatment of choice for thyroid cancers, at least thyroid cancers that are not treatable in any other way. So those are all common causes of hypothyroidism. Other causes of hypothyroidism, iodine excess. So iodine deficiency can cause hypothyroidism, but consuming too much iodine can actually damage the thyroid gland. So you have to get enough. Too little is not good, too much is not good. Certain drugs can affect your thyroid production, so lithium, interferon alpha, some anti-epileptic drugs, and then diseases of the hypothalamus. So if you're not producing adequate levels of TRH, you're not going to be producing adequate levels of TSH or thyroid hormone. So Hashimoto's thyroiditis is an extremely common cause of hypothyroidism. This is an autoimmune disorder, and we have oftentimes with Hashimoto's disease, we have autoreactive CD4 T cells that stimulate the production of autoreactive CD8 T cells, those cytotoxic T cells, and also autoreactive B lymphocytes. The autoreactive B lymphocytes are differentiating into plasma cells that produce antibodies that are anti-thyrocyte antibodies. This is sometimes called TSI. TSI stands for thyroid stimulating immunoglobulin. And immunoglobulin is just another word for antibody. This antibody, okay, I'm sorry, TSI, I'm sorry, that's not. TSI is actually part of this other autoimmune disorder. I got a little bit confused there, sorry. No, the anti-thyrocyte antibody in Hashimoto's is an antibody that acts classically. It is going to attack those thyroid hormone cells, the thyrocytes, as are those cytotoxic T cells, and those thyrocytes are going to die. And as they die off, you have fewer cells being able to produce thyroid hormone, and it results in that hypothyroidism. Okay, so this is sort of classic autoimmune condition. Now, there's another autoimmune disorder called Graves' disease that we're going to talk about in a moment, but this one is a little bit less classic, and it results in actually hyperthyroidism. So we'll come back to that to Graves' disease. But it's very similar. We have autoreactive CD4 cells that produce these TSH reactive B cells. They produce an antibody that's the one that's what we call TSI. This antibody, right, actually binds to the TSH receptor and can activate it. So this antibody acts as an agonist for TSH. So instead of triggering cell death, it actually stimulates those thyroid cells. And we end up with excess thyroid hormone production and hyperthyroidism. So we've got two common autoimmune disorders related to thyroid dysfunction. Hashimoto's leads to hypothyroidism. Graves' disease leads to hyperthyroidism. So what do we see with people with hypothyroidism? Thyroid hormone is a hormone that primarily has metabolic effects. It's going to have a significant effect on basal metabolic rate. It's going to have an effect on cell division and cell growth. And so the effects of hypothyroidism are going to be profound metabolic effects and profound effects on cell survival and cell function. So what we see with hypothyroidism is we see muscle weakness, right? As muscle metabolism and muscle cell growth and proliferation go down, we see this sort of muscle weakness. We see the quality and the amount of hair on people's heads change. So hair becomes sort of coarse and brittle. This is mostly a metabolic change. We also start to see a thinning of the eyebrows, especially like a loss of the lateral eyebrow. So somebody's eyebrow sort of like they have like half of an eyebrow, it sort of ends. There is a type of edema that we see in tissue with hypothyroidism called Meigs edema. This is not a pitting edema. This is a water accumulation in the extracellular matrix. It doesn't pit, but it does create this sort of edema. And Meigs edema will affect the function of cells. So Meigs edema is something that's going to potentially affect the brain. So you can start to see a change in cognitive function and reasoning. There's something called Meigs edema madness that is a change in your ability to reason and emotionally regulate. We also see Meigs edema affecting the heart, and the result is this cardiomegaly, right, that can really affect heart function. We also see edema in the periorbital space and a puffiness, right? So we can see this sort of facial puffiness. The tongue gets a little enlarged, again, that Meigs edema. People are going to look not well. They're going to have these pale faces. Their voice will be a little hoarse. Gastric atrophy. So the cells that line the stomach are going to decrease in their metabolic activity, decrease in their survival rate, and what you can end up with, and also the muscle in the stomach gets very weak. So that gastric atrophy can really cause a lot of GI dysfunction. It can especially after people eat. So people can get extremely tired. They have this reduced rate of gastric emptying, prone to indigestion. So it's really uncomfortable. People are prone to constipation, again, reduced muscle function, reduced metabolism. Females can have ovulatory problems, missed periods, right? And then we also see some peripheral edema, edema of the hands and the feet, And then people who have hypothyroidism, they're going to be tired a lot. They don't have a lot of energy. They're going to have sort of unexplained weight gain, right, as their metabolic activity goes down. They're also going to be very cold intolerant. They're going to feel cold everywhere. When your metabolic rate goes down, your heat production goes down, and so your body feels cold all the time. Now, hyperthyroidism is going to be associated with elevated levels of circulating thyroid hormone. And the general causes, most common cause is Graves' disease. Graves' disease was that autoimmune disorder that produced this antibody, that thyroid stimulating immunoglobulin that mimics TSH on the TSH receptor, and so it increases production of thyroid hormone. We can also have intrinsic diseases of the thyroid gland. So it could be multinodular goiter or a functional adenoma in the thyroid gland. Okay, so this is basically benign growths of the thyroid gland that overproduce thyroid hormone. And then we can also see excessive production of TSH by the anterior pituitary. This is that thyrotroph adenoma that we talked about earlier. And again, this is very rare. Thyrotroph adenomas are the most rare, but they're going to overproduce TSH. And that overproduction of TSH is going to cause a goiter, and it's going to cause overproduction of thyroid hormone. But of all of these causes, Graves' disease is the most common. Now, so what do we see in terms of signs and symptoms? What we see is, again, muscle wasting, right? This excessive metabolism is actually overworking the muscle, and we see muscle wasting. We see this sort of fine hair. The hair gets sort of thin and fine. We see this thing called exophthalmos. That is a bulging of the eyes. So somebody's eyes look like they are bulging out of their sockets. Okay? That's because of a retroorbital edema that sort of pushes the eyes further out into the orbits. That's a sign that you can kind of really notice when you see somebody with sort of bulging eyes. If they also have some other signs of hypothyroidism, that you can suspect that. Goiter, hypothyroidism. You'll often see a goiter because of elevated TSH or elevated TSI, right? Thyroid stimulating immunoglobulin. We also see profuse sweating, right? The person's going to be increased metabolic rate, increased heat production. They're going to feel hot all the time. It's going to be the opposite of hypothyroidism. They're going to feel hot all the time. And they're not going to feel tired. In fact, people with hyperthyroidism, they feel like they are super restless. They can't sit still. They've got a lot of energy, right? And it's because their thyroid hormone levels are so high. Tachycardia, high output heart failure, right? Basically this wearing on the heart because of this increased workload on the heart. Weight loss. People will have unexplained weight loss. Okay. Oligomenorrhea, so they are also having menstrual problems. They will have missed periods. They will have anovulatory periods, and you can also see tremor. Right, this agitation, this increased metabolic rate can also cause fine tremors. Okay. And one thing, particularly with Graves' disease, one thing to keep in mind is that we really have a very different kind of hormone axis with Graves' disease. So if we consider the normal axis, right, with TRH stimulating the production of TSH, which then stimulates the production of thyroid hormone. Okay, that's the normal axis. Now, when we see Graves' disease, with Graves' disease, what we have is we don't have any disease that is affecting or I shouldn't say that, we're not seeing impaired production of TRH, we're not seeing impaired production of TSH or of thyroid hormone. Instead, what we now have is this new stimulator. We have this thyroid stimulating immunoglobulin that is stimulating the production of of thyroid hormone. So as a result of this antibody, we have elevated levels of thyroid hormone. Now, those elevated levels of thyroid hormone are going to result in excessive negative feedback onto TRH and onto TSH. So in Graves' disease, what we're going to see is actually less TRH, less TSH. But because thyroid hormone, there is no negative feedback that can control the antibody. The antibody is being produced not within the thyroid gland, not within the anterior pituitary or the hypothalamus. It's being produced by plasma cells, by B cells that are turning into plasma cells. So the thyroid hormone level can't control the amount of TSI. So despite the fact that we have low TRH and low TSH, we have this elevated TSH and the elevated thyroid hormone, and that thyroid hormone is going to continue to get elevated so long as that thyroid stimulating immunoglobulin is there.